So good morning, everybody. It's a little weird talking about sex and capacity when I'm really kind of talking to myself. Bear with me if I get lost. Just a few things about me that are going to help you understand why I talk about this and who I am. So for the last 30 years, I've been in geriatrics, and for the last 15 years or so, I've owned Elder Health and Living for 14 years. It's a memory care community. And now this year, I am the medical director and no longer the owner, which is great. I'm originally from New York, which means I talk fast and I use my hands a lot. If I lose you, you can type in a question, and then Angela will let me know that something's out there and hopefully tell me. No questions are too weird. Okay, so the topic today, I kind of think it's written backwards: capacity and consent. Let's talk about sex. I actually think we need to know about what is older person's sexual abilities and when are they sexual, how does that all work? And then we're going to go into capacity and consent. So bear with me as we go through sort of aging things. Uh-oh. My little advancer isn't working. They have taken over. Hold on. Stop share. Share screen.
It's live, folks.
Okay, so
anything can happen.
And it will. Yeah.
And Liz, if it gets glitchy on your end, we can always pick it up on ours.
Okay. Stay near your phone. Okay. Okay, thank God I have a IT person. All right, so here we go. I have no disclosures, nothing. All right, the basics, normal aging. So we're going to go through men and women. We'll start with women because they're a little bit more complicated, and talk about things that happen as you age regarding your sexual abilities and changes. And I always like to start with, there's two real issues. One is estrogen and one is gravity. And, you know, the loss of estrogen does a lot of things. I mean, it affects lubrication, it affects sexual arousal, it affects, you know, muscle tone, your ability to fight infection. It does just so much. And the decline in it and loss in it can cause a lot of vaginal problems like vaginitis, increased urinary tract infections, which affect a woman's ability to have comfortable sex or even to want to participate in sex. The other factor that always amazes me is gravity. And I think people don't realize how much gravity is pushing down upon us and causing everything to kind of fall down. So, you know, you've seen some old ladies, their boobs are down around their waist, and that's quite normal. And they maybe get a little kyphotic, they get a lot shorter. The other problem is internally things are falling out. And I love talking about this to 20-year-olds when I'm doing in-services and preparing them to work with older females and say, well, one day, you know, you're going to see a prolapsed bladder or uterus. And they're like, oh my God. Yes, uteruses can pop out. That's usually fairly treatable, right? You can get a hysterectomy, not too hard. Bladders can also kind of pop out through the vaginal opening and cause problems with urinary retention and with discomfort and bladder infections, et cetera. A little bit harder to treat, especially depending how old they are. Usually if they're already living in a care community, it's possible to have some bladder suspension surgery, but that becomes challenging. We try putting pessaries in, a little device that holds it up, kind of like a diaphragm. In my experience, women with dementia, if you try to put a pessary in there, they will inevitably go right down there and they'll pull it out and they'll wash it up with soap and water and they'll put it on the windowsill and have it all ready. And then I'll go reinsert it and we'll play that game for a bit until we realize, no, that's not the answer. So it becomes challenging for them to treat that. We end up doing a million things, and a lot of times it's just a manual as they're urinating, helping them to pee. way more information than you want, I'm sure, on women, but there you have it. Men, totally easy, right? They have almost nothing going on. I put the prostate here. It's not normal aging. Like with women, estrogen and gravity are normal aging. With men, there can be prostate problems. It's so common that we're going to talk about it a little bit and how it interacts with sexual function. And so the prostate is this great gland that's job in life is to expand during sexual arousal so that, you know, men will ejaculate semen and not also pee at the same time. Whoever invented us decided that was a really cool thing, and so it's all good. However, with aging, it's common that this prostate just starts growing, and it can pinch off the urethra, the part that goes from the bladder out, and cause men to go into urinary retention. It's very common, especially in nursing homes and care communities, that the first time we find out that there's an enlarged prostate is when they're in retention, and there's usually a bladder infection associated with it. They haven't urinated in a while. Somebody finally puts a catheter in there, and, you know, out comes a liter or two of urine. My uncle actually had this, and this is a liter bottle, and he literally had 2 liters when he went to the ER, and they finally catheterized him. And I said to him, I'm like, Uncle Craig, you know, didn't you feel this? He said, well, I was still peeing a little, and, you know, it seemed okay. He ended up having prostate cancer. The problem with diagnosing enlarged prostate, either benign prostatic hypertrophy or prostate cancer, is that it comes on slowly, and guys are not as likely to seek medical attention as quickly as women. And it's not their fault. You know, women have had contact with the medical practitioner really since, you know, menopause, or I'm sorry, since menses and needing PAPs and all the rest of it in their early 20s. And men don't really get asked to go get wellness exams almost until they're 40. And then I don't know about you, but it always seems funny how the ad that they use to get men to come in and have a physical is that guy in the doctor's stethoscope around his neck. He's got the white lab coat on, and he puts his finger up and he says, come see me, you need your exam. Now, if I'm a guy and I see that finger, I am not going to go see him. So I really think the exam should just be the stethoscope, and like, I'm going to listen to your heart and lungs, and then, you know, kind of work up to doing a rectal. But at any rate, I'm not in charge of that social advertising. But this prostate thing comes on slowly, can be a problem. If it's benign prostatic hypertrophy, just big old prostate for the fun of it, sometimes they'll go and do surgery to debulk it. Sometimes they will give you medications to shrink it. If it's cancer, frequently they'll do surgery and or chemo. All those surgery things can result in problems with erectile dysfunction, which is problematic for sexual intercourse. Viagra can help and those type of medications, however, not always effective, and it can become a real strain with partners trying to continue their intimacy, switching from this sort of goal-oriented intercourse habit that they have to something that is more around intimacy and connection. So we're going to talk a little bit about that as we go on. So basic aging things that, again, this is all going to come into play when you're talking about and thinking about older people having sex. In case I didn't mention it, they really do. Something like 87% of adults over the age of 70 are continuing to have sexual relations. So if you're thinking they aren't doing it wherever they are, assisted living or nursing home or in the community, you need to rethink that. But some issues, I think these are kind of good to keep sexual activity going. So vision, you can have visual changes as you age. You require 2 to 3 times the amount of light to see what you saw when you were younger. And when you're 70 or 80, you'll need 2 to 3 times the amount of light. Now, this might be good for enhancing the intimacy, or, you don't need to turn the lights all the way down to have that same mood, because you'll have the lights on and nobody sees each other anyway, and it's all good. Hearing, as you get older, normal hearing changes, harder time locating sound. And the reason I bring this up around sex, because all this is leading to that, is that hearing loss in one partner or the other can cause a lot of marital strain and partner anxiety and irritability. And so if you don't hear your partner in the other room saying, hey, can you come in and help me? Or did the mail come yet? Or was that your daughter on the phone? Or whatever the conversation is, you get a little irritated, and then you have to go out and say it again, and then I didn't hear you. And hearing loss is actually one of the sort of final blows if there is going to be a divorce. This can kind of put them over the edge. I can't take it anymore. You won't go get hearing aids. This is too much stress. The other problem with hearing loss is that if it goes untreated, if low hearing goes untreated, that part of the brain, the auditory part of the brain, actually begins to atrophy, and you have an increased risk of dementia. And so untreated hearing loss and dementia, again, put a strain on relationships. I always tell families, or partners, you really need to go see the audiologist. You need to get a hearing aid in there ASAP, and to preserve your relationship. Touch, less sensitivity in hands, and need for more. It's sort of a catch-22, because you have less sensitivity in your skin and sense of touch. However, your skin is so fragile that if you are, doing any cuddling or petting or whatever, you can actually cause bruising, which is not really fun. So there's this balance there. Sense of smell as you age diminishes. Your olfactory sensitivity, that can be good, that can be bad. For me in geriatrics, it hasn't happened yet. I keep waiting. I don't know how I'm still working with this old population and have an exquisite sense of smell, but it does diminish. And smell is one of those kind of endorphin things, and we don't even know that it's involved in our sexual excitement, but it is. We just, perfumes and colognes, they're all developed so that we have some arousal and some attraction. So this loss of smell can cause some issues. Sense of taste diminishes as you age. You need 2 to 3 times the amount of salt, for instance, to get the same flavor that you had in your 20s as you do in your 80s. So I always think when I see old people salting their food to death, it's really, they just want it to taste like something. And so taste sensations and oral abilities can become enhanced or reduced. And so oral sex sometimes is improved with this decreased sense of taste. Okay. Chronic diseases and aging, and again, all pushing towards this physical intimacy. Cardiac problems, heart disease, history of heart attacks, hypertension, make it challenging for persons that have cardiac disease to feel safe or comfortable that there isn't going to be a cardiac event during their time of sexual intimacy, and can take a lot of counseling and even some rehab to help them feel confident. How much do I need to be able to do physically to actually engage in sexual activity? And it's probably more than you think. I mean, you have to be in fairly good shape. We're going to talk about that in a minute. Incontinence, as you can imagine, gets in the way. Urinary incontinence and bowel incontinence, not all that much fun. COPD, respiratory problems, endurance we're talking about there can be challenging. Arthritis, as you can imagine, pain in hips, back, hands, wherever, can limit your experience. And dementias like Alzheimer's or vascular dementia, Parkinson's dementia, also create interesting effects on sexual arousal and your sexual activity. There's problems with, I can't remember, I don't know who you are, or I can't remember if we just had sex, or, you are some stranger, get out of here. A lot of cognitive things affecting the intimacy. Medications. So we all know medications are horrible for the elderly, and yet they are on tons of medications. There's folks here from Canada. I want to give you guys a shout out. You've done really well in geriatrics on deprescribing. You have some great clinical ways of how to deprescribe and good apps for that, which has been helpful in my geriatric practice. But medications interfere with lots of things. And we'll talk, lowering blood pressure, drying out oral orifices, all kinds of things. Endurance, we talked about as challenging. And then life values around sex, habits. People don't change that much. Everybody thinks, oh, when she gets older, she'll be nice, she'll be sweet grandmother, she'll be something, something, something. Whatever your belief system is around that is delusional. I'm just telling you, you really are who you are as you age. Unless you get some dementia, you really stay who you are, your personality. And your sexual habits tend to stay the same. Resentments build, especially after retirement. The risk of divorce goes up with retirement. Alcohol use goes up with after retirement, and that can affect sexual intimacy. Just kind of this loss of imagination, this, unexcitement and inability to try new things, rigidity, low libido, complication, alcohol, marijuana may or may not be helpful or not. Cultural influences on senior sexuality. This is from the Oregon Fair, which I can't tell if you can see these, but these are walkers and, nurses going around. Availability of partners becomes challenging. The notion of masturbating or self-gratification, depending on your values and your historical norms around this, can be a new experience. It could be just kind of not something that's acceptable to you. If you don't have a partner, you're not going to engage in that. Although I have had some very older folks who have learned about masturbating. My story that I always tell, when I was like 30 years old, I had a patient come into the clinic. It was a geriatric practice, and she came in with a shoulder pain. And I'm thinking, oh, well, this is arthritis. We'll put her on a NSAID for a little while, Advil or whatever it was, and all was going to be good. She denied washing windows or anything. Well, it's just a flare-up. And so it's the hand on the doorknob as you're getting ready to leave the exam room. And she says to me, just as I'm grabbing the handle, do you think it could be my vibrator? And I'm like, oh, come on, really? 30, for God's sake. And I turned to her and I'm like, she said, well, I was watching channel 500 million, whatever it was, and they were talking about vibrators. And okay, good to know. And then she said, so I went down to Payless and I asked the clerk there, a very nice young man, if he would show me where the vibrators are. And so he brought me over and he showed me this nice vibrator, but it weighs about 2 pounds or so. And so I went home and I tried this, and for the first time in my 85 years of life, actually had an orgasm. And so then, oh my God, I just, kept doing it. And I think it's too hard on my shoulder. So she had gotten something to vibrate her muscles, one of those big, huge machines, and worked great. Then we had to have a whole discussion about smaller vibrators, and which all of you, if you're in geriatrics and you talk about sexual function, you should be aware of how to help people find vibrators. And the physician I was working with at the time thought it was a little odd. And it's before the internet, so I really literally had to go find pamphlets and brochures. At any rate, so sometimes that's happening late in life. Cultural attractiveness we talked about. People don't feel as attractive as they get older, and there's a lot of age discrimination about aging in America because we are a very youth-oriented society. There's taboos about age differences, although I think this is improving. That, you know, older men, younger women has always been okay, but older women, younger men has been a little bit of a push, but I think we're actually getting over that taboo. So good sex and aging. Again, if you're working with older adults, you need to kind of have a few things in your pocket for these conversations. When you're doing your wellness exam, when you're doing your physical, you should always include some questions about sexuality. And if they're having difficulty, as Dr. Ruth says, you know, really lubrication is the answer. Used to be KY jelly was all there was, but really coconut oil, there's all sorts of lubricants, and you just tell folks, go out, go to the drugstore, go to the herb store, healthcare, really almost anywhere, go and get oils. And at the end of the day, plain old coconut oil works fine as a lubricant. And what you're trying to do is prevent that micro abrasion and pain, and thus inability to relax and have intercourse or even oral sex because of the pain. Think about the time of day if you're counseling. So, you know, after dinner, going out, not that anybody goes out to dinner at this moment, but remember when we used to go out to dinner and then you'd have a few drinks and then you'd go home and you'd have sex and all was great. As you get older, you're exhausted by all of those events. And so if you are retired and you can have sex in the middle of the day when you're alert and not exhausted, no kids around, it usually works well. If there is impotency issues, dildos are effective. If there's chronic pain issues, you got to treat that first, right? You got to take your Advil or take your muscle relaxant or whatever it is that you're using and prepare for having sex. And again, vibrators and masturbation. And these are mine from all the patients I've seen over the years of what can be helpful and what isn't. So this, for me, I think it's like preparing for a marathon. So keeping older adults sexually active is very imperative to their sense of well-being, to their cognitive function, to their staying happy, essentially. But they got to stay in shape to be able to be successful at sexual intimacy. And so I always talk about, you know, you got to work out 3 times a week. You got to do strength training. You got to do endurance training. You got to do some stretching. You got to stay in shape. And in nursing homes and assisted livings, you know, there's always that little gym. Some people go to it, but usually not. And people can have some challenging experiences trying to stay sexually active with their partner, purely because they're deconditioned. And we kind of overlook it. We expect old people to not be doing as much, but I expect them to be doing as much, staying strong and in shape and well into their 90s. And lots of studies show it's totally possible, but you need, get this, you have to work out 6 days a week for 45 minutes and dividing those things. So 3 times a week, the strength, 3 times a week, endurance, walking long hikes and stretching. Be well rested. If you have low libido, investigate testosterone. Again, health food stores seem to do better at this, and some of the alternative pharmacies. It's the drug companies have not gotten into prescription testosterone for women, creams, but sometimes you can get the homeopathic kind of pharmacies to do that. Viagra, talk about it. Gummy bears, no research on this working or not working, but try anything. Alcohol is a catch-22, right? So if you have too much alcohol, you're asleep and it's all over. A little alcohol to sort of get you in the mood in the middle of the afternoon may be good. You have to experiment. Be clear about expectations. Is it always about achieving orgasm? Is that realistic? Is it about intimacy? Having a conversation between partners. Again, if they've been together a long time, this can be a challenging conversation. A lot of times it helps to have a counselor or a social worker or nurse practitioner, somebody bring that up and talk about, is it realistic that that's going to happen every time? Imagination, think of different ways, new toys, new ideas. Talk about just basics of sex with old people. It's amazing what they don't know. Remember, you have lots of time. There's not a rush, and remind them they're never going to get pregnant, so it's all good. Yeah, have dates, candlelight. Okay, so these physiological things become challenging, and everybody wants to stop being intimate or having sexual relations when there's incontinence. I say, let's treat it. Let's see if we can get this out of the picture. So limit your fluids 2 hours before. Be sure you empty your bladder and put something under your bottom so that if there is incontinence, it doesn't like get all over the sheets and make everything like miserable and people feeling embarrassed. You know, the set of the little plastic ones from the hospital, which get all messed up. Some client told me about using that, and he's like, oh, anyway, no, get those quilted ones that are rewashable. They're called Jerry pads, and you can get them at medical supply places or online. Incontinence of bowel is a problem sometimes, and I suggest they clean out things. They do an enema before they have sex. They just get rid of all possibility that that's going to be present so that they're not afraid and limited. Arthritis is interesting, right? So if you sit around because you're in pain, because your arthritis hurts, you're going to have pain. If you get up and walk around the block and do exercise, you're going to have pain, but you feel better. And so continuing to be sexually active, even with arthritis, you need to figure out ways, you know, so change in positions, times of day, pre-medicate, yeah, be a little more creative. Dry, fragile skin, you gotta lubricate everywhere because you're constantly getting skin tears and bruises and all kinds of things. Performance anxiety, we talked about that, and just having some conversation about is this, what is intimacy? Is intimacy purely about intercourse, or is it about being together and showing each other you love each other and that there is a connection? And I think women typically want more intimacy, connection. Men are more outcome driven, but that can change as aging occurs. And again, just more of a dialogue. Like we talked about, fear of cardiac arrest. It's like preparing for a 5K. It's doing those workouts. It's being able to go up a flight of stairs without being short of breath. You can pretty much do that. You're okay to have sexual intercourse, but you got to be in shape. Let's talk about STDs for a minute. So even way back in 2005, and this just keeps creeping up, 15% of new HIV cases were folks older than age 50. And so seniors living in retirement or senior housing or assisted living, wherever, believe that because pregnancy is out of the picture, they don't have to worry about STDs and they don't wear condoms. Well, if you have multiple partners, if you have more than one partner and you don't know their history, you have to wear a condom. And I think women over the age of 50 have not had to have this conversation in a zillion years, but if they find themselves widowed And men too, they need to be sure to have condoms and to go buy them and go to Planned Parenthood or wherever and pick them up for free. And Planned Parenthood does work with older people, and they have a really nice program, by the way, for older adults and sexuality. STDs like chlamydia, gonorrhea. When I started my practice, never even checked for these. Now, not so much in my memory care community, but when I was still working in the clinic, was beginning to have to look for these and treat them. All right, so part 2, care communities and sex. Oh my God, we hate that. Well, number one, we don't want people in our care communities, right, to be sexually active. We just assume they all be happy little old adults sitting there doing not much of anything. First, we're going to talk about sort of predatory behaviors, and then we'll talk about more consenting. So sexual predators exist in the world everywhere, and they age. And I think sometimes we forget that they age and they have never been caught as a sexual predator. They've molested women or children. Something like 7 out of 10 women have been molested at some point in their life. So that means there's a lot of men who have been predators, certainly not that many been convicted or in jail or have any history. In the last 10 years, we've begun to be able to ask if there's any history of having been arrested. I think it's kind of the wrong question still. I don't think we'll ever get a clear answer. So I just teach to my staff and to others that you have to really be aware that they are the residents in your community, and they may be the staff, and they may be male or they may be female. It's predominantly more men still that are predatory. And just as they did prior to being in a care community, they go after the most vulnerable population. And those are usually the residents that can't speak that well, that don't yell out, that don't have family that visit, that are not able to protect themselves. So assume they're there, set up your facility, talk to your administrator or owners of the company or whatever it is, and put cameras all over the place. Now, the hard part with cameras is you can't have them in the bedroom because it's a violation of privacy, but you can have them every other place. And we began here to put cameras like all over in the hallways and the dining room, the living room. And what we can see is, if there's some resident or staff person that's always going down this hall and into that room that's not really their room, it's like, we can catch that and say, well, this is probably needs some investigating. It helps to give you at least some information. Especially, I think we're good at picking up residents. Our community is so small. Nursing homes are fairly good at picking up resident to resident unwanted advancements when it's really clearly unwanted, but not great. There's still rooms that are way at the end of the hall, and people can go into them without the camera seeing. Trust the creepy feeling. Again, I've been saying this for years. When you work with other care providers in a community of elders, if there's some caregiver there that gives you the creeps, I want you to investigate it. I don't want you to just push it aside and say, no, that's not happening. There's tons of studies on women and our innate, to this day, ability to be nice and to override this instinct. And it may or may not be true, but you got to investigate it. So if you get that creepy feeling, I don't know if any of you have ever had it, you probably have, maybe you overrode it quickly to be polite, but it's the one where you say, God, he just gives me the creeps, or there's something wrong. I want you to pay attention and dig deeper into it. You know, talk to others. Hey, you know, does Bob or Charlie, do you feel anything when you're around them? And check that out. You know, I don't want you to accuse somebody of something that hasn't occurred, but I also don't want you to not pay attention. And then keep your eye on things. If you follow that person like the next shift, and there's a resident that is generally kind of either blasé or happy, that's now really fearful and crying, and you know, she didn't fall, nothing acute happened, you know, who was working on that hallway, what was happening, and can we go deeper? I have to tell you that when you report, or if you suspect or report this, almost impossible to get convictions, almost impossible to really figure out if there's any cognitive impairment. It's unless you catch somebody in the act, it's almost not going to be believed, although we know that it may be happening. And then you have to really, if you believe it's happening, you haven't caught them in the act, you need to look at your schedule, you need to see who's working with who, you need to be put them on day shift where there's lots more people around. You need to take precautions because you can't prove it, so you can't really fire them, but you doesn't mean you can't take precautions. You got to locate your most vulnerable residents and move them close to the hub, wherever the hub is, closest to the nurse's station, closest to the lobby, closest to whatever, the dining room, something, so that people walk by. Now, in assisted living, all the doors are closed, which is always kind of interesting. I mean, it's their apartment, they have their own privacy, but it also means anybody can walk in there. Not everybody locks their door. And so trying to keep an eye on that. Now you have the right to go into any apartment that lets you in, you knock, you go in, that's legal for other residents to do that. But it's also challenging for care staff to sort of keep an eye on if there is a relationship developing, is it mutually consenting? Just something to think about, locking, unlocking doors. I think some places are better at having people, you know, wear their key, lock their door so that wanderers can't go in and do whatever, but other places not so much. In nursing homes, the doors are almost always open unless there's personal care occurring, so you can peek in and see who's in there and what's going on. Same in most memory care, the doors are open, and it's really easy to do visual checks. If you have a vulnerable person, I put sensor alarms near their bed so that, you know, even if they get turned off fairly quickly, somebody's going to pay attention. Is there another resident going in there? And maybe they don't know. So the sensor alarms, all different types now. Most of them don't go off near the bed anymore. They go off by the nurse's station, or they have an app on their phone or on their watch or something that tells them somebody's in that room, and they can go check it out, even if they're not a fall risk, but because they really don't move. Just having it there so that you know who's entering their space and can begin to think about that possible scenario. At night, management has to do night shift checks sporadically. You just got to show up in the middle of the night and look around. I think we have so many community-based care in Oregon, which are assisted living and memory care and residential care, as well as adult foster homes. All of these are not licensed professionals that are providing care. They're trained, but they aren't licensed, and they move from care center to care center to care center. There's, because they're not licensed, if they were fired from one facility, nobody will ever know it if they move to another facility. If you're fired as a nurse from one facility, that goes to, you know, the State Board of Nursing is going to know why and how, or if you're a CNA, why and how, and that will be findable. But with direct care staff that are unlicensed, frequently they'll be asked to leave or not directly fired, but asked to leave, and then they go on somewhere else. But there's been suspicions about them that's not proved, but they just go to another facility. And so it's hard to get any background because you call the last facility they worked at, and all they can say is they would rehire, they would not rehire, and then the person can give a story about how much work they had to do and so much overtime. I mean, there's a lot of legitimate reasons why you leave a place of employment, but just red flags. If you ever see multiple moves, a red flag as a person, as the HR person hiring, why didn't they last? What weren't they doing? And it's also complicated now with COVID. Oh, I have to stay home with my kids, and I tried to go back to work. I'm afraid. There's now a whole scenario about if you don't feel safe because of COVID, you can stop working and get unemployment again, which makes it, even though vaccines are offered, they can refuse the vaccine and not feel safe. So it's very hard to get employees in long-term care at the moment, probably anywhere, because of not wanting to work and be at home for legitimate reasons, or just don't want to work. Pay attention to distressed peeps, especially if they're content. Just a change in mental status. Don't assume it's at UTI. We make a lot of assumptions, and I think we need to be a little bit more vigilant about, is there inappropriate behaviors occurring? And I know that, we always are thinking about resident to resident and capacity and all that, but I want you to keep in your mind staff to resident. And you're like, oh, Liz, come on, they're ancient. It doesn't matter. A predator is a predator. Okay. So flip this, when you go into a care community and say one person's in the assisted living or the memory care, and the other person is still, other partner is still community dwelling, and they are trying to get some time together to have intimacy, it's very challenging. Assisted living, probably easier, lock the door, but staff still, despite years of training, knock and unlock the door and go in frequently, not all, and some staff don't. When you put things like do not disturb on the doorknob, that always feels like weird, and everybody knows they're doing something, and then the whole staff talk about it, and then there's a lot of discussion at the lunch table, and et cetera. So be a little more creative than do not disturb, maybe, under construction, or if the person is in a semi-private room, the Medicaid patients are frequently in semi-private or some private, and the other resident has the right to be in their room whenever they want to be in their room. And it can become challenging to find some intimacy time. And you got to kind of negotiate the two roommates and see if there's time to be in there when we get the staff involved and say, can you take him for a walk? Can you do something to allow some time for intimacy to occur? Usually families just take folks home if they still want to visit with them. Now, in the COVID world, so this is like the normal world. In the COVID world, very hard to have families in the building. If the building is under executive order, if they've had one COVID outbreak, and then the whole place shuts down, visitors can't come in unless they're declared essential visitors. So essential visitors are people that need to be there at end of life. So the family will be there at end of life. If you're a guardian, you're considered an essential visitor. But if you're just a plain old spouse, you're not considered an essential visitor. When you're not under executive order and you have no active COVID cases, or even just a positive staff that was asymptomatic and isn't on campus, for 2 weeks, you test everybody. all staff, all residents, and you get 2 consecutive weeks of all negative, then you can open up, but still the visiting has to be in a subscribed place. So like in their room, they're technically supposed to say 6 feet apart, which I'm never quite sure how you get a demented person to understand that piece, and it has yet to happen. We were open for about, I don't know, a week or 2, and then had a positive staff person and closed back down. But legally, forevermore, families can take folks out and put them in their car. They're supposed to take them out, keep masks on, even if everybody's vaccinated. At this point, these are the regulations in Oregon, stay 6 feet apart, which is impossible if they're going to be in the car. So that one doesn't make sense to me. But at any rate, they can put them in the car, they can take them to doctor's appointments, or they can take them home. And so typically they go home and they visit and then they come back. And so facilities are constantly struggling with this. Well, so we have to have all the families still pray that they've either been vaccinated or that they don't have COVID, because it's this constant thing. So having intimacy during COVID has added a whole nother layer of challenges to being together. So being in the room in the house is probably not happening at all for the last, since over a year ago, but taking folks home is more likely occurring. Determining consent when dementia is present. So there's 2 issues when you're determining consent. This is decisional capacity. You don't have to have a global cognitive non-demented brain to determine capacity, but you have to have a decisional capacity in that moment of who that person is that you choose to be with. And there's a couple things about it. One, residents have the right to associate with whomever they want to associate with, whether they're married or not. They can associate with whom they choose. That's their patient right. That's their resident right. Sometimes families get stuck on this and they say, oh my God, but she's married. And it's like, I know she's married and she's choosing Jim, and she's clearly choosing Jim. And for us to forbid them from being together is denying her the right to associate with whom she wants to associate. We have the duty to protect, so we need to make sure that she is choosing Jim. We need to find out if Jim is in some way putting his wishes over on her, pressuring her into some kind of relationship. And then we got to watch it constantly. So when you're trying to tease this all out, all hands on deck. Everybody has to be part of this assessment and ongoing evaluation. So all staff that work with the residents that are perhaps developing a relationship need to be part of the dialogue. The spouse, if there is one, needs to be part of the dialogue. Hey, your wife, Amy, is, getting involved with Tom, and they seem, they like each other. They're sitting by each other. She's reaching out to hold his hand, and that's what's happening. And if the spouse at that point is saying, hey, nope, no way, we're going to have that discussion about right to associate. But typically what can happen is that they end up moving that person to another wing or to another home on if they have cottages or whatever their model is, another neighborhood. And if the spouse is not wanting her to have any relationship with any other man, then there's usually some kind of a move, which is a little distressing for everybody, but usually effective. Not always effective. Have you noticed in your practices out there in care that if there's a resident that has tried to have a relationship with another resident that I can move her or him to every single house. I got 9 of them at Elder Health and Living, for instance, and they will find a partner. There are people that are pre-programmed to be in partnership. They just are. Either they've been married a bunch of times or they've been married a long time, but they are programmed. It's their personality and their identity to be in partnership. And they're, really after a few days, they're finding somebody and they're adjusting their collar and they're checking their hair and they're making sure they're okay and they're bringing them over their coffee and they're doing something to begin a relationship, and it will happen over and over again. I've had folks, even with this personality, moved some guys to an all-male house, and they have found a male companion to be quite close with and care for, because it's their nature to be this caring in partnership person. They just are. Back to this, all the stakeholders, the children, if there's children, need to have a dialogue with them, need to help them understand what's going on. If you believe that they're mutually attracting to each other and that they are wanting to be together, and the children are, not having any of that, it's a lot of education and a lot of time. I had one woman who was literally in her 90s who pursued this gentleman in his 70s. And I mean, she just beelined. There was group community activities just before COVID. And anytime there was a dance or a bingo or really anything, she would make a beeline for him. They lived in separate houses. She wanted him to come to her house to visit. They ended up being quite involved with each other physically, emotionally. And the children were furious. And I kept saying, no, she's choosing. And they thought it was terrible. He's younger. And I said, yeah, but your mom is really, looks pretty good, in great shape. And she's very attractive. And she's putting herself out there. Believe me, she was the instigator of the whole thing. Well, then it comes out later from the kids that, mom was having an affair on dad as he was dying. And she had affairs through most of their marriage. And the children were just furious. And they put her in care into one of the homes at Elder Health at the time that was all female, intending that she will not have another relationship. However, she is true to herself and had another relationship. But all of their reaction to this was really based on their anger and issues with their mom through their whole childhood, through their adulthood. Frequently need to get the state involved, the caseworker, if there is one. If there's discussions about this, we need to be sure that they're happy and that we've met their bar of assessment. Sometimes the primary care person is involved, practitioner. Not always, but usually there's a fax or two depending on the facility talking about this. Care plans need to include a nursing assessment, and the nursing assessment really has to be, they're fascinating to do. I do them all the time, and every one is different. So when I say, make sure they can hear, see, walk, whatever, it's very challenging to know, are they choosing this person? Because they may not know their name. They may call them a different name. I had 2 women that just adored each other, and each of them thought the other was a male. And they called each other their husband's names. So did they really know? But if you tried to separate them, there was none of that. So they always met each other first thing in the morning. They always sat by each other. They always adjusted each other's everything and took care of each other and held hands wherever they went, sometimes kissed. And they were choosing each other. They didn't know their name. They didn't know each other's names, but they were both hard of hearing. So that hearing thing comes into play. They called each other Bob and George, I think it was. And they were happy. The family was happy. They both luckily passed away close to each other because it would have been another huge loss. But they had a relationship together for a couple of years. Trying to decide consent is always about, is it mutual? Is she going towards him? Is he going towards her? Are there any signs, anything that suggests either one of them is afraid or trying to get away from or just annoyed by the other? This can be challenging too, because all relationships have ups and downs, and sometimes people are irritated with each other. They say something the other one doesn't understand. It's even more fun in dementia care. And then they're mad at each other and they don't want to be near each other, or one does and one doesn't. Does that mean that it's an unsafe and non-consenting, or are they having a fight? And so teasing that out can be challenging. But 9 times out of 10, it's pretty easy to decide and to determine if they like each other and if they're choosing each other. You watch them sit by each other. You don't direct anything. They sit by each other. They hold hands. They seek each other out. Sometimes they want to, be part of going into the bathroom with the other one, and staff kind of gets involved and has to be creative. No, she's got to do female things now or male things. It's okay. Sometimes they want to go into the bedroom together. And if everybody's consenting, they are allowed to have a physical relationship. The problem is with dementia and memory care, are they consenting every minute? Our mornings are consenting and afternoons they're tired and non-consenting. Is today they consenting and not? And so it's a constant assessment. So even though you do this big nursing assessment, yes, she's going towards him and he's going towards her, and they have about the same level of dementia. Neither one is pursuing the other. There's no predatory behaviors that are being identified. But then you also need to be present for when they are bored of each other or irritated with each other, annoyed, and help split them up for those times. And then document it and have them go back together. Usually it works smoothly. Sometimes the relationships are just too volatile and you end up moving both people because you can't keep an eye on when they're mad at each other and when they're not. And I'm sure that's how all their lifetime relationships work. And so it is a challenging thing to determine consent in the moment and the decisional capacity in the moment. And we're always asking, again, nurses and professional staff in nursing homes, but remember, community-based care is mostly not nurses, and it's direct care staff that are trained employees, but you're asking them to make decisions about capacity. So your service plan has to be very specific. Do they smile? Does she go towards him? Does she reach towards him? Do they sit by each other? Do they pat each other? Are they stay together? Is there any sign that she doesn't want it? Is she pulling away? Is she running? Is she sitting across the room? All those things. So it's teaching them and having it specific in your care plan is how you determine if it continues to be a safe relationship or not. And you're constantly documenting. Again, consenting behaviors, smiling, welcoming, happy, seeking each other. I mean, it's like high school, really, you guys. When you see this, when you see these relationships coming together, it's really quite joyful. I mean, they're like, oh, there you are. It's like a whole new day. I thought I lost you. And I wake up in the morning and there you are. And you sit at the table. The other thing I think people don't quite appreciate sometimes is that even though somebody has dementia and it can be fairly advanced, they're always choosing who they like. Even if it's not relationship or anything else, but they will choose the caregiver they like best. They will choose where they want to sit, or who they don't want to sit by becomes very clear. It's amazing how many residents have very impeccable social skills around holding their fork right and closing their mouth when they chew, and dining values. And when they sit next to somebody that eats like a slob, it totally offends them and they'll never sit near them again. They have this awareness, they have values about who they are choosing, who they are associating with, and they have that right. And it's really based on a lot of who they are as a person. So like I said, some people are always going to be in relationship and some people are never going to be in relationship. They've been, solo their whole life. They're never going to be in partnership. But everybody chooses every day who they want to be around. If they're able to speak, they're saying nice things. Isn't she beautiful? Isn't he great? I love him. I mean, it's very clear. And non-consenting behavior is equally clear. Avoiding contact. Again, we're back in high school and you're trying to get away from them, and isolating, fearful expressions. I mean, it is really clear where they'll say, I don't like him, or get him away, or get out of here, or, very basic things, or even just putting their hands up. They have clear signals that, no, this isn't somebody I want to be with. Now, if they are completely obtunded, so to speak, if they have no verbal skills and they have, sort of advanced Parkinson features where they don't give any facial gestures anymore, then you have to assume they aren't consenting, because you can't read them. They have no verbal way, and they can't consent. They might like it, they might not, but they can't consent to it. And so those are those vulnerable, fragile people that you really have to be sure that somebody isn't predatory, or even not in a predatory way, but just attracted to them for whatever reason. Sometimes they look like their wife, and so they go and they want to hold hands and they want to put their arm, and the person is literally not moving, not doing anything because she can't. Then the assessment is not able to consent, does not have capacity. Dementia is so advanced, they're not aware of the person's intentions and whether to accept them or not. So I thought we'd do some case studies, and usually it's more fun to do this with people, but I'll just do them by myself here.
Liz, it's Angela.
Yep.
Hey,
yes.
If you want, we're at 60 participants. We could try and unmute folks. And then those that are willing to engage, if they want to come on camera as well, we can open that up. So if that would help to have a more robust discussion.
I'd just like to know if people have had this happen ever, what to do if my wife wants to have sex with me but forgets who I am. These are real life experiences, by the way, and they're a bunch of answers. So if anybody wants to pop in and if they've had that experience, what did they do with it, or what didn't they do with it, or sure. Can you do that, Angela?
Yes, Kelly is working on that for us.
Okay. My door creaked open. I'm going to just quick close it.
We've lost a couple of people. I think we might have scared a couple of folks with the idea. Oh, well, you brave hearts out there. Come on. Kelly, can you?
Yeah, if there's any volunteers that want to either just do audio or do audio and video, let us know by the chat box, or you can do the raise your hand option, and I will switch you over.
Easy enough.
Just wait for volunteers.
Do we have any folks in APS, and that's Adult Protective Services for us in the States? Because I'm sure you have these scenarios playing out. I am sure you get called in with issues around, is it consensual or not? Is it abuse or not? So feel free to weigh in.
So while you're looking, I'll talk about this case study. So it was the husband who came to see me. His wife had advanced Alzheimer's. he was, they were still living at home at the time. And he was concerned if it was still appropriate, and it's amazing how many partners really want to know, is it still appropriate for me to have sexual relations with my partner if they forget who I am? And we had a long talk about it. And I asked him questions like, does she, even if she doesn't know you, your name maybe, does she like you, whoever you are? Are you somebody she's physically attracted to? She's not calling you daddy or something. Is the time that you are intimate, is she ever fearful or upset? Or is it, what is the experience of being together? Is she happy and enjoying that? And are you? And if that's the case, you're giving her a great gift, a great joy. And she is with you in that moment. And so with Alzheimer's and other types of dementias, you got to look for those moments of connection. So is there somebody on that's going to be brave? Brenda, are you going to unmute her? Can everybody see Brenda?
We have visual.
She's got mute on hers.
Brenda, there
you go.
But I'm coming at this as a retired lawyer, not as
word.
No. I know, not as somebody with professional experience, other than you're always looking out for somebody else.
Right. So. Oh, okay. So as a professional lawyer, did you any thoughts about this case? Any thoughts about that?
I guess, well, I would advise them that anything that makes their wife happy is something that they should be grateful for and not at all feel guilty.
Right. Yeah. And that's pretty much where we ended up. Yeah. And at some point he actually said, it's just too upsetting that she doesn't know me. And he said, no, we're not going to do that anymore, because it felt so lonely, actually, to be with somebody who wasn't that person anymore. And she ended up moving into memory care, and he totally adored her and cared for her in every way, was visited frequently. But there is a point where I think it becomes obvious that it's just too awkward. Is there a Maria Elena something or another? I don't have a picture.
Aranda? Maria Elena Aranda.
I just have an ARA.
She is from
Hi.
California. Hello, Maria.
Hello.
Did you want to say something?
I just had I think that, well, first of all, the presentation has been fabulous. Thank you so much for all of the information. It's really been quite eye-opening for me as a social worker, because this honestly is a topic that I usually don't bring up in my assessments, because when I assess the older folks, they're usually with their children. And so it's a topic that is not a safe topic. But I had a quick question. I have a woman that came to me who said that she does home care. And most of her clients are older folks, retired folks living in a retired community. And she said she was very close to one gentleman where she did all of his home care and, all of his IADLs. And then one day she showed up and he was ready for intimacy. And she was so surprised, she was shocked, and she didn't know how to handle it. And he said that he thought that she was really attracted to him and that this is what he wanted, what she wanted. So she tried to very politely say, oh no, I'm sorry, I hope you didn't misunderstand, and I just work for you. And at one point she came and said, I don't know what to do with this. So she proceeded to let the family know, the daughter. And then this poor man was so shamed.
Oh.
So the whole thing was just so blown out of proportion. And I was just wanting your thoughts on all of this.
Oh, no. I mean, there's so many levels of misunderstanding. And depending how cognitively intact he is, typically fully cognitively intact, they don't misunderstand a caregiver from a potential date. That's very unusual, and I would think there's something suspect there. He can ask, but he, for sure, there's been a lot of caregivers that become girlfriends or partners, but there's usually a lot more dialogue than just show up one day. And so I would wonder about his cognitive abilities, and then if he's not reading the cues right? So that's sort of the frontal lobe pieces, like he's just not getting, she's a working person, she's doing this thing, she's part of an agency, whatever, then that's cognitive deficits. And he's not going to be able to fully understand or accept or whatever. He's going to feel bad because he didn't read the cues right. And probably just switching to a different caregiver is what is going to work better. We have more advanced dementia folks who, are quite impaired, and then they have this 20-year-old young female caregiver giving them a shower, and they get an erection. They are like, come on, and the caregivers are saying, that's so inappropriate. No, that's so inappropriate. Well, it's not something that one should proceed to assist with, but it's not really inappropriate in that sense, because somebody's giving them a shower. All of their remote history in their brain is, shower, woman, naked. Okay, we're on, let's go. And so helping them not feel embarrassed at that time, it's like, oh, no, sorry, no, I'm going to close the curtain and I'll be back. I'm a caregiver. No, that's not what we're doing. Just really clear, no energy, like, no, you're a bad person. No, oh my God, oh, that's awful. None of that. Just no, we're not doing that. I'm your caregiver. Say who you are, what you're doing. I'll be back. And, if they self-gratify and you return, okay, let it be. And it's like normal. It's a normal sexual expression of misreading that situation, but not really misreading it, if you know what I'm saying. Does that make sense? I'm sure it doesn't.
Yeah. Thank you.
Very much so. One of our participants weighed in with the same words. Alicia, it's a normal human function.
Great.
Thank you.
Okay, another case study. These are faxes that have come to me over the years. John is being sexually inappropriate. Can you order Haldol 1 milligram 3 times a day? Yes, no. I don't know how many providers are out there and how many faxes you've gotten, but this one, there's anybody want to weigh in on all the problems with this fax? Anybody out coming in, Angela?
Well, should we explain what Haldol is for to begin
Sure.
with?
Okay. I always think I'm talking to nurses, so
Sorry.
no, I know.
If you recognize Haldol, you go, oh yeah, that ain't gonna happen.
Okay. So Haldol is an antipsychotic. It's one of the older ones, as it turns out, and it's been around forever. We used to call it vitamin H in rehab 30, 40 years ago. But it's used for aggressive, agitated behaviors that are of a psychotic nature, and TID means 3 times a day. Anybody want to weigh in now, or should I just dive in?
You're getting some good commentary in the chat box. We've got some nurses and some other professionals that are astounded as well.
So when I used to get these, and still I have caregivers who are, young and inexperienced and saying, Liz, really, John is like, he just wants to be with Mary. You got to do something. You got to give him something. You got to stop that. And they're just so alarmed that it's so inappropriate on every level because they never imagined, one, that John or Mary were still sexual human beings because they're 20 and those folks are in their 80s and that whole concept is beyond them. So, breaking this down, I mean, number one, it's not a fax. Number two, it's a discussion. It probably, there's, inappropriate, like we were talking about earlier. What is inappropriate? Who is he inappropriate with? When is it? What's the situation? What's going on? And is he, in the shower and, makes sense to him that this is, you're obviously turned on by me. You put me in the shower naked. What'd you expect? Is he, predatory, going towards other females in the facility and you can't stop him? Does he need to be in an all-male house? I call my all-male house, the house of men that love too much. And do they just need to be there? Is it really, he had one incident where he asked her if she wanted to be his wife. So you can't really do anything with this without so many more layers of information. And, Hellbell's probably never going to be the ticket, unless he's beating the crap out of everybody and there's physical aggression associated, then probably Hellbell still isn't the answer. But you might end up using medications for physical aggression. So you got to remember, especially with frontal lobe type dementias, where they lose all of that empathy and ability to perceive others' willingness or unwillingness, they don't see it. And so they pursue what they want to pursue. And if they don't get it, their sort of left brain takes over and goes to anger. And so, what are they doing? What part of their brain is affected? And how are we going to help them not get to that place? It's just deeper. Any other comments in there that you read, Angela, that will add to that?
Well, we had an ICU nurse chime in, and I'm sorry, it's hard for me to toggle in between.
Oh, come on.
Well, let me get that name for you. It's Jessica, I'm going to say Reeker. Sorry if I mispronounced that. And as an ICU nurse, we would never do this. And a good comment from Cassie R is medicating with Haldol for sexual behaviors, exclamation. What other interventions have been attempted prior to asking for this medication?
Right, right.
Yeah.
Right.
So
they skipped everything and gone right to medication.
Here's a good one from Oregon Vets Home in Lebanon, Oregon.
Yeah.
Comment is, we've had staff say, oh, that's so cute at the beginning of a relationship, but as it progresses into heavy petting, etc., staff will call it inappropriate and want the RCM and doctor make it stop.
Right. So, so much education around, intimacy, heavy petting, and actual intercourse. If everyone decides they understand what's going on, and nobody's being taken advantage of, it's really hard for young staff to get. And that, starting out, isn't that cute, to, they really are interested and they're really going to pursue this relationship to a physical connection. Daughter brings her mother in to see you and wants to know if you think she should be intimate with George at the memory care community. So she's asking, kind of like that first one, is he still able to consent with his wife? And do you do that in a memory care community? And I won't repeat what we talked about on the slide with the other couple, but the piece about the memory care community, I want RCs and administrators and whomever, social workers in those communities, to think about giving families permission and helping them find a place of intimacy, because they believe that it's not allowed, or it would be frowned upon or something. And we need to normalize it and find those solutions, like under construction on the door, or some way to not make it such a big deal where they can be together. And so if, you know, again, we go back to is George liking his mother, you know, his wife still, and all of those things come into play. But just taking a moment sometimes in the care conference or whatever for spouses to say, you know, again, pre-COVID, you can visit and we can make a private area for you if that's something you want, or you can take her home with you. You know, she doesn't come back all upset. She seems okay. And she really loves you. She's really attracted, and help them work through what's going on. Any comments, Angela?
Not yet. I know that you guys have had these situations happen. Anybody who's been working with older adults and you're sliding over into that area of dementia, you've had these, should we call them ethical dilemmas for some people? They feel like ethical dilemmas for some people, when actually I think some of it is the basic education that we need and normalizing older adult sexuality while being able to do a good job of screening for predators. I'm talking while hoping somebody will chime into the chat box, and we have a shy bunch this time.
Okay, I'm going to move to the next. So this is kind of getting at the VA statement. So staff are in conflict over the rights of these old demented people to have sex, versus she loves John and they light up whenever they see each other. I'm calling his daughter, he's married. And so I wanted to get at the level of anxiety that the care staff have over sexual relationships, over intimacy. It can disrupt a care team very quickly. And people seem to polarize around this topic pretty quickly too. It's right, it's wrong. It's, you know, it's a black and white to a lot of folks. And it takes time to go in and really not side with either, but talk about, well, let's see what John's doing. Let's see what Mary's doing. Let's see if they are choosing each other, if he is choosing anybody. I have a guy now who really loves all the women quite a bit and would, you know, has got to go be in the men's house probably, but he's very courtly about it. And he's so sweet, and he'll go up to anyone and start singing to them and hold their hand. And if they're in agreement, he would take them into his room and have fun. And then he'll pick somebody else and somebody else. And is he choosing each one intentionally? I think he's choosing each one because he thinks they're pretty and he likes them and whatever. And the females may in the moment like him or not. It's very challenging to determine that. But he's so wanting partnership. And it's too challenging to determine because there's like 6 ladies in his home and he will literally contact any of them that are available in the moment. And so trying to teach staff, are they choosing him in that moment is beyond possible. But talking about his need for intimacy, and yeah, he's going to take it wherever he can get it. Is he predatory? Is he lonely? Is he just seeking intimacy as part of himself? I mean, he's a guy that really seemed like he was a romantic husband when his wife was still alive, and, you know, was very demonstrative and kind of carries that through, but doesn't distinguish between one and another, which makes me then say, you know, he needs to be with the guys that love guys too much, that love women too much, sorry. And help staff understand I'm calling his daughter, he's married, you know, we're going to include the family and letting them know this is sort of a team discussion, and having an understanding of, you know, again, the right to associate versus the duty to protect. And let's just break it down and talk about whoever is agreeing or not agreeing. I'm amazed how many spouses in my career have said to me, oh, great. I'm so glad she's found somebody. Now she won't be lonely. And I'm like, wow, that is truly a devoted spouse that's more concerned about their well-being. I can't be there all day to keep her company. I'm so glad she's found somebody, or I'm so glad he's found somebody. I feel less guilty. And then I've had the complete opposite. She better not be with someone, blah, 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 blah. I had one wife tell me, he's done this too many times, put him in the men's house. And I'm like, oh, okay. So she finally got the final word. So it's all over the spectrum with families and with staff, and just taking it down to, let's look at John, let's look at the other person, let's see what they're doing and what their ability to consent is.
Liz, can we take that and kind of flip the situation? Lee is here. He's joined us. He has a question about how this works when it's the staff member that the adult is focusing on and not another resident. Lee, you want to chime in?
Yes, I've worked with a caregiver, a young male. He'd worked at a facility. It was a combination of assisted living, memory care. And a lady moved in and she fell in love with him, and they couldn't separate him. She chased him all over the place and tried fondling him, and he's having a hard time.
Right. And so we have maintenance guys, mostly guys, one gal, who go into the houses. And as you know, there's a lot more women than men in care facilities. So when they see a guy, these women, they all watch every single thing. They change the light bulb, whatever. They're like glued because they just don't see that many men. We have some male caregivers, not a ton. So partly it's just like, it's so unusual to see this guy. And if they're a caregiver, oh my God, I'm in love with them. And, you know, they flirt and they throw themselves at them and all this. And we work with the male maintenance and caregivers in the kind of similar way that we do women that are giving showers. You know, oh, you know, thanks, you great, good seeing you today. You look great, you're healthy. You know what? I gotta go. And I gotta go. Sometimes you have to say, I have to go see my wife and, you know, make it clear to her that this is not a relationship, this is not okay. And then sometimes say, I'm not comfortable with that, and no. You know, I typically teach you don't say no to people with dementia because it makes them feel horrible. The only time I deviate from that is around sexual advances that are not comfortable, because the message has to be super clear, not mean, not degrading, not humiliating, but constant and clear. No, no. And give the mom voice, no expression, stop, no, and leave. And just leave and give nothing. I mean, because again, caregivers, male or female, try to be nice. Oh, she's demented. Oh, isn't that nice? And at first, you know, you're like, oh, yeah, she gave me a pat on the butt. Well, that's good. Or, yeah, I tell her how beautiful she is, which we want them to do. And but if they're misperceiving it, then you got to go to this really firm no. And if possible, he needs to work in a different wing or different part of the facility where she isn't constantly triggered by seeing him. You know, we've had to move female staff, we've had to move male staff, you know, everybody, because if they get a beeline or the staff gave off the wrong vibes to start with, the demented person can't let go of, you know, especially if they're kind of obsessive. And again, I'm going to go that frontal lobe thing where they have such obsessions. And if a caregiver becomes the obsession, I'm not breaking that. You say no till the cows come home. You can't break it because they've latched on. It's an obsessive compulsion that, again, really characteristic of more frontal lobe damage than typical Alzheimer's. They can't remember 2 seconds. I mean, Alzheimer's are so easy, but frontal lobe dementias are much more challenging because they have good verbal skills, which is awesome. And they have this obsession with really no awareness of the other person, like this loss of empathy, loss of understanding that they're saying no. And so you just remove them because you're not changing that. You're not changing. I can give drugs till the cows come home, won't change it. You're it. So does that help?
It helps some. The problem was he changed wings at the facility to try to get away from her, and she keeps following him. He changed shifts, and she still chases him around. So he, poor guy, he says, I try to hide from her, but she finds me in the closet.
It's almost undoable. I mean, unless he can literally be away from any place that she's allowed to go, she will find him. So again, that frontal lobe presentation, we had one woman that had to clap. That was her obsession, and she would clap, clap, clap. And literally from the moment she woke up to the moment she went to sleep, she had to clap. I was never going to stop that behavior. And with Alzheimer's, you can say, oh my God, yes, fun times, and then move on to something else. With frontal lobe like dementias, you can't. And so, we had to hold her hand and go for walks, and then she'd stomp her feet. She couldn't eat in the dining room because she would take the fork and bang, bang, bang. She had to have that rhythm thing going until she got too old to do this, until she got so impaired. But I was never stopping the behavior. And staff would say, why don't you give her something to stop the behavior? There's nothing that I'm going to give her because she believes, it's almost when you think of OCD and younger people, their belief, their obsession is their lifeline. I mean, they believe if they don't wash their hands 50 times when they get home from work, that they will die, or their family will, or whatever their entrenched belief. You don't change OCD behaviors very much. You need a lot of, cognitive retraining, and, SSRIs or antidepressants can help move them a little, but not much. And when it's dementia on top of that, you don't move them at all. So you have to move everything around them. And I don't know where he's going. Yeah, maybe he needs to grow a beard or look different. Yeah, she'll still know him.
He finds him no matter where.
Oh dear. Any questions about anything? Anybody?
We had a couple of new folks join us. I know that a few of you have comments.
Or comments, questions or comments?
I had a question, if I may. I just had a comment about everything you were talking about, but the complexity of the cultural factors adds even another layer. And then LGBTQ relationships within the facilities, right? The reaction from staff as well as other residents. So I was just, going to throw that out.
Good. No, and I think it's worth mentioning. I kind of forget it because we've had, I don't know, 3 or 4 gay, some male, some female residents here, and their partners come visit. And I think it comes from the top down, right? And so if the administration and the management team normalize it, that's their spouse and or partner or whatever they choose to be called, and it's super normalized, staff go with the flow, and I really have not had anybody give pushback, oh, that's gross or something. I think they have given pushback when 2 guys that were previously heterosexual suddenly decide to be together and hold hands and kiss, and they are like, oh my God. And we do that whole same thing. We just make it so rote about, is he choosing him? Are they, do they understand, and are they safe with each other? And, nothing's predatory, and they have the right to be together. And, they didn't go any further than holding hands and kissing sometimes. Not sure what would have happened if they tried to be more sexually intimate. That might have been more of a challenge, but I think in a facility, if the facility leadership really normalizes gay, lesbian, or bisexual and transsexual, if that gets normalized from the admission assessment, the pre-admission assessment, to the service plans, to just the way when, like I've done the pre-admission assessment and my nurses have done service plans that we then just lay them out and review them with staff, like very matter of fact. And, this is her, this is her partner. And yeah, but I imagine in some cultures in different facilities that, gay relationships are not acceptable to them on a personal level, religious level, cultural level. And then you really have to put your hat on that we take care of everybody here, that these are our residents, that they have the right to associate with whom they want. And then help them talk about it, because it's just so new to them. They didn't even know that, gay, lesbian people got old, let alone came into a care community, let alone their spouse came in. It's just so new to them that just talking about it. But I think everything goes underground so quick. Oh my God, no, that's so taboo. And the more you can just talk about it, the better. I mean, the minute I can't tell you how many 20-year-olds have been freaked out, and we've just talked about it and said, well, where do you see yourself? You're married, you have some children, are you still sexually active? And do you imagine that stopping when you're 50, 60? Well, it doesn't. So they feel the same way you feel right now. Would you, if I told you tomorrow you could never have sex again, how would you feel? And they're, I said, that's what you're saying about this person, that they can never have sex again. They can never have intimacy again. Is that okay? Just whatever language works for them. And you got to get comfortable with all the words and just saying it and putting it out there. And then, I always like to start on an in-service with some of the aging stuff and all the oohs and ahs go on. And then, really working on relationship things and how do we keep everybody safe and allow them to have intimacy.
And Liz, this segues into another question that Dr. Davidson would like to present. And Dr. Davidson, I'll let you make the intro and pose your question.
Okay, I hope you can hear me. Okay.
Good.
I do.
Okay. So I'm 65 and about to retire, hopefully someday, but I've spent a couple of decades doing inpatient psychiatry and in long-term care facilities and with people with traumatic brain injuries. And of course, we've seen over that time an endless variety of variations on these kinds of things when you add psychosis and mania to frontal lobe injury and that sort of thing. And the request to use psychoactive medications to stop sexual behavior is relentless. But that's not what I wanted to talk about. One thing we could never resolve, I want to hear what you think about, is when legal guardians prohibit sexual activity for their charges, because this is pretty common in long-term care facilities. And some say, for example, the judge ruled she lacked capacity consent. I consent for, I'm saying no. And if I catch her, she's being sexually assaulted in your facility, blah, blah, blah. And we could never find a legal opinion to back us. We would go through all kinds of extraordinary measures to keep people who wanted to have sexual activity out of, hidden closets, beds, and it always felt wrong.
Right.
And yet, I'm wondering if there's any literature on this, or if you have any different ideas about what we could have done differently.
I do. So although a judge determines if you need a guardian, if you're unable to manage your own affairs and that somebody needs to help you, they, at least in Oregon, it's interpreted that they can't limit who you associate with. It is not legal to deny associations. And so again, the onus goes back on the facility to ensure that their duty to protect is in place, but also the resident rights. It's very clear, your resident right to associate. It has nothing to do with the guardian. You know, if the guardian doesn't want them associating, they need to move them, period. Because the facility actually is responsible for allowing them to associate after we've determined that they are mutually understanding. And again, it's not a global, can you manage your own affairs guardianship? No, it's a very specific, do I know you? Do I like you? Are you the person I want to be with? And can I be with you? And there, again, that's a facility patient's right decision. And that's how they've seen it here in Oregon. And that's when, so with those cases, I would get the senior and protective services out here. I would say, okay, I'm getting some pushback from the guardian, and here's my assessment. Here's what what we see. I can show you on video, what they're doing, how they want to be together. And I'm getting pushback from the guardian. Can you come in and assess if in fact this person if there's any injury to the person, if there is, any sense that this is not a safe situation, because I can call senior protective services on anybody. It's usually I do first to say, oh my God, I think something's going on here, or, the family or resident to resident, we have to self-report. And I would ask for an opinion from the state on this one and say, here's the pushback. I feel like I'm in a dilemma. I'd get the ombudsman, I'd get everybody on earth in there because they have resident rights. And that's where you hang your hat over and over again.
So the right of association includes the right to have sex with basically people who the guardian and possibly even we, the staff, consider ne'er-do-wells. They're not predators, but just, so if we always think of ourselves in a sort of parents patriae, like if, for people who are chronically psychotic, even on medication, would we want our son and daughter to do this? And it was, because association, when you have a mental disorder or an impulse control disorder, is something that is pretty spur of the moment. And
hi, I was in the chat. My name's Lisa. I actually serve as a legal guardian, and I would be happy to offer a little perspective if that's okay.
Great.
Okay. I didn't plan to be on video. Anyways, so what I would say is I work for the Multnomah County Public Guardian's Office. So we're professional fiduciaries. We are a team. And what I would say is this: it's a complex issue. There are a few things that come into play. There's absolutely dignity of the person and the right to associate. Where it gets tricky is around health and safety. So what I would say, what our team does is, I've had clients for whom I evaluated the situation with the team at the facility, and I know my client pretty well, and I got some information, and I was like, yes, this seems safe. Absolutely. If things progress to a little bit more intimate level, then we'll do some planning around it. So you can care plan, you can do safety planning. I have some folks who experience traumatic brain injuries, who have no impulse control, who will desire intimacy with someone, and literally right after the intimacy occurs, they perceive that they've been assaulted. So everybody's different. And with a person like that, I would never say no. I mean, one of the most fundamental things about being a person is we need to have relationships and we need to have connection with others. So just saying no, but it would be a yes with some significant planning. because if something happens, we have to do the best we can. If someone has been deemed needing a guardian, it means they need some extra support around health and safety. So that's where we come from it. You know, that's our perspective. So I don't know if that's helpful. It's just sometimes you have to do things mindfully and with some intentional planning so things go well.
Right. And I think, the psychotic part, are they, again, in the moment, are they psychotic? Are they delusional and hallucinating and paranoid?
Right.
And well, then, no, that's not a time they're going to understand or appreciate who they're with. And I think if they're so unstable, like I used to have a mental health home that we oversaw, and their schizophrenia is so unstable that they can't, choose what socks to wear. I don't think they can appreciate, a partner. They might like hanging out with them at lunch for 10 minutes, but then they're seeing things and talking about things that aren't there and misperceiving what's going on. So I think you really have to do just such an in-depth assessment of their cognitive situation. And again, you're stuck with caregivers in the moment because, again, they might be stable and hopefully you can stabilize them psychiatrically on some medications that they're in our world enough to say, I really like my girlfriend, and, I think you used the term ne'er-do-well, and the girlfriend is still living in the community, because we would have this a lot, and they want to see her, and it was it would become unsafe, but we've stabilized the person in the care community, in the mental health facility. And so they still are choosing her, and they're not delusional or hallucinating, but they're choosing a bad partner. Well, do they have a guardian still? And can the guardian say, she's a bad partner? That becomes challenging because they've stabilized. And then do they still need the guardian? Probably they'll petition again to not have guardianship, and they go on and off of guardianship in mental health. I'm glad I do geriatric old peeps in nursing homes, and because mental health, their abilities fluctuate so much. So thanks for that, you guys.
That was robust conversation. And we have another one that is going to open a can of worms from Maria Elena, who has a question about folks who have a background of sexual abuse and how this is manifested as they age and develop dementia. The fears, the trauma, PTSD is manifested, and they feel that they're being assaulted repeatedly. Can you comment on your experience with this topic?
Yep. So 7 out of 10 women at some point in their life have had some form of being molested. So it happens all the time, and it probably happens more than we are aware. Families don't always know what the situation was or if it occurred, and we figure it out because as their dementia progresses, they are more and more, if it's Alzheimer's in particular, back in their childhood situation, and they're saying things to us like, no daddy, no daddy, no daddy, or very clear that they're misperceiving what's going on. It takes a lot. I mean, it helps to know, and then we can be sure to have female caregivers if it was a male that abused them. So that helps. Always tell whoever is doing the intake that this has occurred, so we can have a plan going forward. It helps to look as nursey as possible, and usually a female caregiver that looks kind of like professional, and to always keep saying words like, I'm a nurse, I'm a caregiver, I'm here to help you. Not too much, because maybe those were the words they heard before, probably not, but we're all girls, it's okay. I've had to have some caregivers, female caregivers that have more of a masculine face, not work in that home because they're misperceived. And so, sometimes I put little bows on them, or I put barrettes in the caregiver's hair. So it's very clear because they're understanding auditory language goes away, but their visual perceptions can stay longer. And so you can make sure they know it's a female that's helping them, because you're asking a caregiver to pull their pants down. And then there's ways to do that. I mean, the hand under hand technique, so that the caregiver is actually holding the resident's hand and the resident is pulling their own pants down. The caregiver's got the skill fingers, we call it, and then they're pulling their own pants down and they're having them sit on the toilet and cleaning them rather than standing in front. Don't ever stand in front and pull pants down. It's violating, and it'll immediately trigger something. So you have to really be mindful of how you're approaching, and that it is in no way overpowering. So you can't, go over them. You're to the side of them. When they're down sitting, you're literally squatting by them. You are not standing over. You're squatting by, holding their hand, patting their back. It's okay. That's just for toileting. And then dressing, it's, very similar. And sometimes they don't want to take their clothes off, so you leave their shirt on. You put a bath towel with a hole, a poncho we call it, over top, so they can take their shirt off underneath maybe and put another shirt on. With that being covered, I mean, sometimes they just need to not feel in any way exposed. Some residents never give a shower to, that they're never going to want to be fully naked ever. And so sink baths with that poncho on and cleaning, I mean, that's a respectful way to do it. You pray they don't have severe incontinence, bowel incontinence, because you really want to clean them well. But you just have to see what their abilities are to accept and feel safe with care. Look at me, I'm like pushing myself back to allow another person in their personal space. And then all those good techniques about going slow, getting permission, holding their hand first and going for a walk, always get permission before you enter their personal space is like times 10.